For decades, politicians have toyed with the notion of a national pharmacare plan. It moved a step closer to reality this month after a federal advisory panel released its preliminary report laying out the building blocks of what needs to be done. Joining us now to explore the feasibility of such a plan, Helen Stevenson. She is founder and CEO of the Reformulary Group. She's also a former Ontario Deputy Minister of Health. And family physician Dr. Monica Dutt. She is Medical Officer of Health and the CEO of the Temiskaming Health Unit and a board member with Canadian Doctors for Medicare. And it is great to see you again back here. And you've been on the program before, but
by video.
By video.
Distance.
So good to have you in the studio for a
Good
change.
to be here.
Can you just, how'd you like to give us kind of the 411 on the preliminary report that just came out that former Ontario Health Minister Dr. Eric Hoskins just unveiled?
Sure. So it's the National Advisory Council on the Implementation of Pharmacare, and it's a quick read if people want to read it. It's about 8 pages, and it goes through a few areas. One is what is wrong with our current system. So it talks about the cost of it right now. So for individuals who often can't afford their medications, we know that 1 in 5 Canadians can't afford to fill their prescriptions. We know that 20% don't have health insurance. So it talks about the fact that many people can't afford their medications. The second problem they talk about is sustainability. We know that our drug costs are increasing $34 billion a year in 2017, growing exponentially. That can't stay the way it is, so we need to deal with that. And then the third issue they talk about is accessibility. So we have over 100 public plans, over 100,000 private plans in Canada, and they cover different things, they have different eligibilities, so it's inconsistent across the country. So they go over that, and then they go into their recommendations. So they have 3 recommendations. One is to have a national body, an arm's length body, an organization that would administer and manage a national pharmacare program. They also recommend a drug formulary, which is basically the list of medications that would be covered for everyone in Canada. And then they talk about information technology, that we need to be able to have a system where everything is recorded, from your doctor or your nurse practitioner giving you the prescription, to going to the pharmacy, to monitoring the safety afterwards. So those are the 3 main recommendations.
Okay, so with that background in place, when the preliminary report came out, how did you receive it?
Well, I thought you did a very good job sort of summarizing the current problem. I think it was, at least when I read it, very broad. And certainly, one of the other key features is it talked a lot about partnership among all the stakeholders, which I would support and I think is key, but I also think it's probably one of the most challenging parts, let's say, of the implementation, getting all of the provinces and territories and on-site, et cetera.
Hold off on that for a second, because
Yes.
we'll get to Quebec
Yes,
later. I mean,
yes,
that's obviously the elephant in the room, so to speak, in terms of getting from where we are to a national pharmacare program. Did you think it was another building block into what will eventually become a national pharmacare plan?
I thought it was, I didn't think it was specific enough to be another building block. And so I thought it was very broad, but sort of in putting it down, I thought, well, this could go either way. This could go towards the more filling the gaps, a more of an incremental approach, and really ensure the people that don't have coverage or have inadequate coverage, for instance, get access to prescription drugs or coverage for prescription drugs. But on the other hand, it could go the other way. So my own read of it was quite broad, and that probably in the coming months, I suspect there's some sort of dynamic tension with respect to how much it's going to cost and what it's going to do, for instance, that's still at play.
Well, you did point out, Monica, that this was an 8-page long report. Yeah. Some people have criticized the fact that they're asking, where's the beef, right? And when you're 8 pages long instead of 108 pages long, they ask you where's the beef. Did you ask that question when you looked at it?
Not really. I think there's something to be said for kind of a short report that people will probably take the time to read and go through. I think as Helen was saying, there were pieces in it there was nothing in it that I disagreed with. There was lots of good information. There was everything that's there, I think, to build a national pharmacare system. I think the recommendations are all, in my mind, somewhat givens that need to be in place if you're trying to develop a national system. So I think when you're asking, is it a building block, it's a small building block. It doesn't kind of go against where I think we should be going. At the same time, I would have liked to see something stronger in terms of recommendations.
In which case, if the idea If the idea is to make sure that as many people who need coverage get coverage, in your view, Helen, do we need a national pharmacare program, all provinces and territories involved, run by, well, they've said an arm's length organization, but let's call it a federally regulated agency, that kind of thing. Do we need that model in place to achieve that goal?
So I would say no. And I'll say no, sort of, let's say, on the backdrop of having been deep in the trenches when Ontario did some big reforms, but also no from the perspective of, I think you lay it out well. I think there's, let's say, I would characterize the sort of choice of what we're doing in terms of, so I think there are a lot of people that feel way back 60 years ago we should have included drugs as part of Medicare. And so is our goal to go back and fix that? Or is it to actually ensure that everybody has access to drugs, right, that is affordable? And so I am an advocate, given that we're 60 years forward and we've got a system in place that, while absolutely it's a patchwork of programs and there's lots of inconsistencies, there's good coverage that's provided. There's excellent coverage that's provided through some plans, but we really need to fill the gaps in terms of ensure that the people that aren't reimbursed for drugs, can't afford to get coverage, are getting coverage, and they're not going without essential medications.
I don't want to oversimplify this, but in essence, you're saying don't throw the baby out with the bathwater.
I am, yes.
I just did what I said I wasn't going to do, but that's in essence what you're saying. All right, conversely, I presume you would like to see the full-throated national pharmacare plan that, quote unquote, fixes what was left out of Medicare 60 years ago.
Yeah, definitely what I'd like to see is a universal single-payer pharmacare program. And despite it having been set out decades ago that it should be there, commission after commission and report after report after many decades, it's still saying the same thing, that we should include it in our national health coverage, provincial, territorial.
Why would that be preferable, given it's going to cost a lot, right? Why would that be preferable to do?
You know, there's been a lot of, if you're looking only at the economic side of it, we know that private plans cost us far more in administration than public plans do. And we can do a number of things like bulk buying and making sure we get our costs down. Canada pays some of the highest costs in the world for our medications. So when you look at the estimates of what we could save, the parliamentary budget officer said about $4 billion, which is kind of seen as a worst case scenario, where it could be up to $7 billion or more a year in terms of what could be saved, because we're spending $35 billion a year on medication. So there's a lot of room to improve our system if we had a public plan.
Let me understand that. The suggestion is that if we had a national pharmacare plan where everybody got covered and took their medication appropriately, we could save our healthcare systems across the country as much as $7 billion annually.
Yep, and there'll be savings from a number of different places. So there's the government savings, because these 100 different plans across the country, they have administrative costs, they have a number of costs that would come together. Employers pay a lot for premiums for health insurance, so if there was one plan, there wouldn't be these multiple different plans. Government would save the money, and individuals, we know that people are paying out of pocket. Even when you have a plan, often there are payments you need to make when you go to the pharmacy, and that's prohibitive to many people who can't afford that. So all across all those areas, people would save money.
Okay, that of course, that $7 billion is an estimate. What do you think of it?
I mean, I think if you have one system, and for instance, you introduced tendering, where you tendered out, or you introduced, let's say, networks of pharmacy, for instance. I mean, I think you could, I don't know if $7 billion is the right number, but you could achieve savings. You know, if I might just introduce one other concept that I think is really missed in the discussion, and certainly missed in a lot of the documentation or the report, is the whole area of the drugs we use. So this isn't just about the cost of drugs. And, you know, back in my days in the Ontario government, we did reviews of pricing, et cetera. And, you know, yes, we pay higher prices, not in all areas though, that's important to remember. But I think what's really important is the drugs that we use too. So there are a lot of opportunities to move people to drugs that are just as effective and less expensive, or some cases, you know, more effective. And yet, you know, I'd say generally speaking, I think the public plans do a good job with that, but I think the private plans don't do a good job of that. And so I think that is something that as a country we should be looking at irrespective of who's really paying the cost. So it isn't just, I'd say, the price. I think there's often a focus on the price of drugs, and admittedly, yes, absolutely, we could, get prices down further, but it's also the drugs we use, and it's our willingness as Canadians to actually consider alternatives when there's alternatives.
We actually sort of had a bit of this debate in the province of Ontario over the past couple of years, in as much as the previous Liberal government brought in a program called OHIP Plus, in which everybody, I think, under 25 got covered for a, not everything, but a pretty healthy list of drugs. And that passed, and there we were for a very short time. The ensuing government came in, the Conservative government came in, and got rid of that, saying we couldn't afford it. And so we are where we are right now. Was that a model for what you would like to see nationally?
In some ways, yes. I think it also showed the challenge of having this piece-by-piece process that one group and one province gets covered, and then it can change very quickly. And it wasn't like we suddenly saw health insurance companies saying, oh, we're going to decrease our prices now because all these children don't come under us or youth don't come under us anymore. So the government was paying, people were still paying their premiums. So it doesn't really work when you try to put this mixed model together. So I think it's actually a good argument to say it needs to be done on a broader scale to actually work, because when you do it in these bits and pieces, it works to some extent, but it doesn't give you the benefits.
Well, I think the argument that the current government was persuaded by was that, I don't know what the number is, you two know, 85% of people already are getting their basic drug coverage covered under their employment plans or Medicaid or, what's that called? That Ontario Seniors Drug Benefit Program, that kind of thing. And that basically a multi-hundreds of millions of dollars of additional spending was brought in to cover the last 15% of people who weren't covered otherwise. And in the view of the current government, that was an irrational expenditure. Have I got that sort of right?
Yes, and so you're right that the plan now was basically the government was absorbing the cost that was previously being paid by private plans. And I can share with you that, there when they estimated, I believe the estimates were that was going to cost $485 million. It ended up being almost $650 million.
Which you predicted that.
Yes.
You were here on this show several months ago.
Yes,
and you predicted.
And it actually was right. Yeah. So it was right. And I think that is a caution, let's say, and having been in government and understanding what it takes to actually implement, right? Not to mention all of managing all the stakeholders. I think those, back to the budget numbers, it is a caution in that it doesn't always pan out that way, right? There are estimates, and they may say reasonable estimates, but there's a lot of infrastructure that would need to be built. There's a lot of disassembling, for instance, that would need to happen that actually is a cost in the system, and that needs to be factored into as well.
What do you think I know you want to say something, but just tell me, what do you think what would be the annual cost? Again, they said $400 million in the province of Ontario. It turned out to be, way more than that. What's the estimate for the annual cost of a national Medicare program? National Pharmacare.
What we need to look at is how much it would cost how much we'd be saving across the different areas. So I guess the first thing is there would be the upfront cost. So there would be the input that needs to go in from federal and provincial, and that has not been kind of worked out to the details that need to be, because that negotiation hasn't even started yet. So you can look at a number of different models, and that's where they're getting these estimates of $35 billion of a cost of what we're paying now. Say we'd save that $7 billion, so we'd put in the $27 billion across all these different areas, and then we'd end up with the savings in the end. So it does depend on the model. So it's that savings in the end, and then the rest is how much you'd be spending on the system.
But if the Ontario example is any example, that $35 billion is more than likely going to be $50 billion.
I don't think necessarily. I think we also need to look at the fact that health insurance companies have far higher administration costs, and they're making a profit because that's what they need to do. So when you look at 2% administrative costs for a public plan versus 20% for a private plan, we are going to not be putting that money into the profit-making entities and having it stay in the public system. I am now a CEO of a health unit, and I see that as our funding isn't getting any higher, we still need to provide benefits to our staff, and the drug costs are increasing, the premiums are increasing. That's our public dollars of a public institution going in towards administrative costs and profit of health insurance companies.
What's the private sector response to that?
So I mean, I'm not sure. The 20% sounds really high, just from what I see, and admittedly, insured plans, so small organizations like mine, and it sounds like yours, we're more in the insured plan model, and that's a different dynamic. But for some companies that, for instance, are self-insured, I think probably more importantly, what the real one of the big differences is. So in Ontario, for instance, the list of drugs is 4,400 drugs. Most private sector plans, not ours, but most private sector plans have 14,000 drugs on them. And so the cost of it is, of course, higher because people have access to more drugs. And so that's, a really important consideration, I think, in the whole pharmacare discussion and moving to one, because I would suspect you could never go, the entire country to one model where you get access to 14,000 drugs. It would bankrupt the country.
Right. So the Ontario plan was 4,400. I think the NDP had a plan in the last election where they were going to cover everybody, not just under 25, but they were going to cover many, many, many fewer drugs.
Right.
So what a national pharmacare plan in your dreams would offer how many different medications on the formulary?
I haven't put together the formulary, so I don't have that ideal number, but I think, as you were just saying, more isn't necessarily better. So we really need to look at this arm's length body. It is more than just the bulk buying. It would also be the evidence assessment of what are the medications that are the ones that make sense to be on a formulary, to be the baseline that everyone in Canada should have access to. People should not have to move to another province because someone else covers a medication that they need.
Since you brought up provinces, let's hit this one on the head right here. There's no way Quebec's going to go along with this, right? Quebec just doesn't. They don't, whether it's the pension plan or anything else, the 9 provinces and 3 territories can do their own thing, and then Quebec has its own thing. So that's 25% of the population that would be out of this potentially new Canada Pharmacare program. Province of Ontario doesn't sound like it's nutty bananas about it right now either. This may save money in the long run, but they're worried about the short run. They're worried about a $13.5 billion deficit in the short run. So there's another 40% of the population that's out. Is this thing dead on arrival?
I don't think it is. I think Quebec is actually a really interesting example because, as you said, they do have a process where they cover everyone, and that larger employers have to offer insurance, employees have to take it, and then there's this fill in the gaps model. But interestingly, what we've seen in Quebec is that their costs have been rising. So they cost about $200 more per year per person for their program than the rest of Canada. Their costs are increasing. People have to pay still out of pocket. So about 10% of Quebecers still can't afford their medications because of those extra payments they need to make. So there is a possibility that if there was a better system that was introduced, there might be an economic argument to say, ours isn't working as well as we thought it would. This might be a better system.
Helen, I'm down to my last minute here. You put your finger up, feel the way the wind is blowing. Did the political realities of the day suggest this is never going to happen?
Yeah, I think it'll be a challenge to have it happen. I think you hit the nail on the head too, in that provinces and territories, unless the federal government is just going to hand them a bucket of money and say, we'll pay for everything, the thought of provinces actually handing that money that they're currently using to cover drugs to the federal government or some variation in between seems unlikely. And, just to get them all aligned on it, I think you're right, they do have different eligibility, different formularies, et cetera. I think it's a real challenge to do that. Not a reason not to do it. I think there are other reasons maybe to more fill in the gaps, but a challenge.
We should reconvene this when the final report comes out and we see whether or not we're yet another step closer to having this thing happen. Dr. Monica Dutt, Helen Stevenson, it's good of both of you to join us on TVO tonight. Thanks so much.
Thank you.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario, helping businesses stay on the right side of change with strategic thinking, insightful decisions, and business leadership. Are you on the right side of change? Ask an Ontario CPA.